Now I would like to request Dr. Uday Gajiwala.
Good evening and thanks to Dr. Kaushik, Vision 2020 and the organizers for this opportunity. Before I talk about investigating, there are a few guidelines which are available. So one that we are decoding right now, Vision 2020 Right to Sight India guideline. Government of Gujarat has published a guideline. There's one shown by Dr. Harpreet, also is from Royal College of Ophthalmologists. And AIOC task force meeting had occurred long back. The guideline is probably still under preparation, but we may see AIOC guideline also soon. These guidelines are available on the portal of Vision 2020 and Government of Gujarat. Anybody can download and make use of. Before I go into the investigation, there is an adverse event reporting committee of AIOS. Online reporting is possible on the portal of AIOS. The information shared there will remain confidential. 2 or more cases, as mentioned by Dr. Harpreet, is considered a cluster, and that's why it needs to be reported. Be it even a task, it should be reported. Due to non-reporting, for several reasons, many episodes go unnoticed. I differ from Dr. Harpreet. Clusters in India are more common than we think about it. Every month maybe a cluster is getting reported, and that is only about 1/10 of all the clusters happening in India. Once we report, the committee gets notified and further action is taken based on evidence. So I request everyone, all the AIS members, to report adverse events on the portal. Regarding the guideline, I'll be talking about the investigation into the cause. Dr. Shanmugam has already told us about the treatment of the patients. Now we need to investigate into why this has happened, where things have gone wrong. So first thing is required to formulate a team that will investigate. There can be a microbiologist, an ophthalmologist, a theater nurse, clinical risk manager, and a hospital manager member of this committee. If you don't have a microbiologist, you can have somebody from outside, not necessarily you will have a microbiologist in your team. There can be 2 different types of investigation. One that you do it yourself and government may have ordered, or an inspection committee may have been sent to investigate this. Not into the ophthalmology, if it's a general healthcare related cluster infection, any cluster is an emergency. So one needs to begin investigation immediately, and one needs to know background rate of infection. Dr. Harpreet mentioned in India we have maybe 0.1% as our background rate of endophthalmitis, but all of us need to understand our own rate of endophthalmitis. We need to confirm the existence of outbreak, laboratory diagnosis using microbiological methods. We need to create a case definition. However, in our case, it's easier endophthalmitis. Only thing we need to differentiate is from TAS. We need to develop line listing by identifying and counting cases or exposures. We need to describe all the surgical data in terms of time, place, and person. We need to remember the patients may have been sent home, because generally we discharge our patients after a few hours from the hospital. So we need to know how many patients are at risk. We need to look at the changes that may have affected the rate of infection. For example, a new staff was recruited in the team, new procedure was being performed, or recently a healthcare worker to patient ratio has changed. Like in Western India, the workload doubles during winter. There's a seasonal variation. Then a new construction going around the theater. And we need to communicate this information to relevant personnel. We need to screen our own staff members and environment. We need to write a proper report, preliminary report, and a final report at the end of complete investigation. We need to summarize investigation and recommendations to the appropriate authorities, and need to implement long-term measures to prevent similar outbreaks in future. Coming to the investigation of cluster endophthalmitis in particular, we need to remember that most of the times it will be failure of sterilization that will lead to a cluster infection, whether it is sterilization done in the hospital or we procured some material pre-sterile from the market. So what all areas that need to be investigated: environment around the OT, pre, intra and post-operative practices, cleaning and sterilization practices, and microbiological screening needs to be undertaken. Regarding environment, there may be some construction going around, or the eye theatre may have been used for some other surgical activity other than eye care, or some septic surgery was done in the same theatre just before we took on the cataract surgery. Again, I'll remind you, we need to look at what was common, because clusters will occur only when common items are used without re-sterilization in between surgeries. So for pre-operative practices, of course, it could be a staff member who may be passing on infection, who may be having URTI, LRTI, skin infection, anything, and is still working inside the OT. However, the other practices also need to be looked at so that we understand whether the protocol that has been followed for cataract surgery is up to the mark or not. There are NPCB guidelines available, there is AIOS guideline available, we have a separate guideline for Government of Gujarat also. Rajasthan government also had published a separate guideline. So we need to follow the guideline particularly given by the government, which will be legal binding to all of us. As far as intraoperative practices are concerned, how many times we are scrubbing, or whether at least we are changing gloves or not. NPCB guideline has made change of gloves mandatory. We did not talk about the frequency of scrubbing. Then fresh set of autoclaved instruments, whether it is used for each surgery separately or not, that needs to be looked at, very important. And whether instruments are left exposed for long periods of time. Sterility and expiry date of pre-sterile material that is used, maintenance of no-touch technique within the theatre, and we should cross-check all the records like patient name, surgeon's name, assisting staff's name, date, which operation theatre, which microscope was used, the type of surgery done. Then in terms of IOL, viscoelastic and saline, the batch number, their sterility indicator, and expiry date need to be checked. I have seen expiry dates gone when the IOLs were being implanted in front of my eyes when I was doing clinical audit of some hospital. We need to look at the logbooks, so we need to check the duty roster, the autoclave records, and we need to check the infection cases also. Post-operative practices directly are not important, but again for the purpose of protocol. Cleaning and sterilization, whether the sterilization is properly being monitored or not. Many times ophthalmologists tend to say that it's not done by me, but we as surgeons are responsible to cross-check whether the activity was done properly or not. Similarly, fumigation and other clinical activity records need to be checked. Proper washing and drying of instruments, particularly the cannulated instruments. Autoclave maintenance and servicing need to be checked. Storage of sterile material need to be checked whether it is done properly or not. Method of packing and loading for sterilization need to be looked into, and date of purchase and proper functioning of the equipments also need to be checked. Need to take cultures from sterile items and non-sterile items. This need to be done on regular basis. However, when a cluster has occurred, we need to recheck everything. And the significance of the organism identified must be decided, particularly if you find the same organism from the patient's eye and from sterile material, then it becomes causative. So when trying to determine the cause, we need to look for common factors, and most of the times organisms enter from surgical instruments, irrigating fluids, or by contamination of the implant. Whatever is going inside the eye can be the causative. I'll not take time in talking about this, but this is taken from one of the inspection reports. I'll not name anybody because these are confidential reports, but the inspection committee looked at the infrastructure part also, human resources related factors also, the record keeping was also looked at in detail, protocol followed inside the OT was also considered in great detail, and statutory requirements and laboratory reports were also looked at. So friends, we need to be very careful, and it is at times difficult to investigate this, but it's better to prevent it. Dr. Harpreet did mention about the green, amber and red alert. It's called traffic light model. This paper is available on the internet. If the p-value of your infections against the number of cases done falls in green, you can still continue to operate. Red, we must stop completely. So reminding you the do's at the, to sum up, we need to stop operative work. We need to recall all the patients operated on the same day for follow-up. We need to check if it was done by the same surgeon or the same assistant or under the same microscope or using the same batch of irrigating fluid or viscoelastic or whatever, whether autoclaving work was done properly or not, whether fumigation was done properly or not, whether sterility of the pre-sterile items which were used was proper or not. We need to set up an investigating team and start working immediately. We must inform the government officers, take culture swabs, do a complete and thorough cleaning, cross-check all the activities of sterilization and pre-operative workup. We need to check the efficacy of the autoclave machine, run a complete check of all the activities as per monthly checklist, keep a close watch on all the patients who are operated, and if traffic light model suggests that we can continue, we can continue. Otherwise, the surgical work needs to come to a stop. Thank you so much, and we hope and wish that nobody ends up with a cluster infection. Thank you.
Thank you very much, Dr.